Thanks everyone for tuning in. When they asked me to give this talk, Advanced Treatment for Chronic Heartburn, I was happy to do it. Since coming out of training and being in my 6 years of practice, over that time I learned what I loved, and reflux surgery is one of those things that I love treating those patients. I love doing the surgery and seeing the massive changes that we can affect through these procedures. There's a lot of moving pieces and details and nuance to the topic, so we'll try to move through things and give everyone a good idea, a good foundation for reflux surgery tonight. In terms of disclosures, robotic training, as per standard, had been provided to myself by Intuitive Surgical at no cost to myself. Otherwise, I have no other ownership interest to disclose. These are the objectives I hope we accomplish tonight. I do want to introduce and review the presentation for Gerd, gastroesophageal reflux disease. We need to go over some relevant anatomy so that we're all on the same page and talking about the same structures and why we're discussing those. The pathophysiology, or how Gerd develops and what the consequences are from that. We need to go over how you get diagnosed. What are these different tests? Why are you having them? What information does it give us? We'll go through medical treatments standards, which many of you very likely have been on or are on currently. Those current standards, also the drawbacks for those treatments, and where we're at right now. We'll finally get to talking about the surgical procedure, the gold standard, Nissen fundoplication, and different variations of that, how it evolved to be that, how we do it, and what our goals are to do that, to complete that procedure. We'll talk about the surgical process, how your recovery and diet changes following surgery, and we'll touch on some newer experimental, not yet mainstream treatments, but treatments that are showing promise and the direction that Gerd treatment is moving. So on to the basics. Gastroesophageal reflux disease, acronym Gerd, characterized by recurrent and troublesome heartburn, regurgitation, or again, reflux. It can be compromising to quality of life, but there are also complications and fallout of Gerd that can develop, characterized by such as esophagitis, inflammation of the esophagus, strictures or scarring, narrowing of the esophagus, and Barrett's esophagus. Gerd should be distinguished from less severe forms of indigestion or gastritis, dyspepsia, whereas those can also have quality of life impacts. There's less of a worry for progression to more serious disease. Characterized by gastric contents refluxing up into the esophagus, producing some symptoms, and also reaching higher up into the GI tract, causing a host of other symptoms. The ones higher up, we tend to see more hoarseness and wheezing and cough, affecting the respiratory tract, where the esophagus meets the trachea. Risk factors for Gerd, first and foremost, anything that increases intra-abdominal pressure. In the U.S. and a large amount of the first world, obesity, increased body mass index will increase intra-abdominal pressure and encourage any intra-abdominal contents to push into any other area that they can. Pregnant women also, later in pregnancy, will see reflux developing as there's less room in the abdominal cavity to allow for gastric contents. We know tobacco smoking has been shown to worsen reflux symptoms. Age is a factor. We tend to see patients as they get older, their reflux progresses, and that's a combination of overall frailty, weakening of tissue planes and musculature. We see GERD is actually quite a first world problem. Up as much as 25% of individuals in the United States have some degree of GERD, comparing that to the third world, less than 10%. And whether that varies with body mass index or diet or lifestyle or utilization of medical care in general, it is a phenomenon that we see. Twin studies have been done looking at why any genetic component of developing GERD, and has been demonstrated that a heritability increase of upwards of 40% between twins, contributing to risk of developing GERD. Looking at the anatomy, we have several pictures here. They're very basic, but they emphasize what I do want to clarify. When we eat, food goes down the esophagus through the chest cavity being separated from the abdominal cavity by the diaphragm, and the stomach, which when positioned appropriately should remain in the abdominal cavity below the diaphragm. Okay, this lower esophageal sphincter or LES, circular muscle at the bottom of the esophagus, is an important structure that we measure a series of different ways with respect to GERD. This is the circular muscle that should, under normal circumstances, be closed and prevent acid and gastric contents from refluxing up into the esophagus, except for during swallowing. There's a period of time where the sphincter should relax to allow a food bolus to get down into the stomach, and then it should close back up. What we see with GERD is this lower esophageal sphincter's muscle strength isn't as high as it should be, and that can allow reflux contents to get higher up into the esophagus. A number of you likely have been told that you have a hiatal hernia. And what is a hiatal hernia? Not many people actually know. In its simplest definition, I tell my patients, well, what's a hernia? A hernia is a hole that something can push through. Those holes can be in your umbilicus, they can be in your groin, they can be in your abdominal wall. In this case, a hiatal hernia is the esophageal hiatus, the hole in the diaphragm that should be about 2 centimeters wide, is larger than it should be, allowing a widened opening that gives an opportunity for the stomach to push itself up through that wider opening, putting part or all of the stomach into the chest. Larger hernias, we can actually see other organs, including the colon or the spleen or the pancreas herniating up into the chest, and those become more complicated to repair. But a hiatal hernia, importantly, allows the lower esophageal sphincter, which should be an intra-abdominal structure, up into the chest, which is a less advantageous position for it to be able to prevent reflux. The muscle is less effective at preventing reflux in this position. So in order to restore optimal lower esophageal sphincter function, it needs to be back down in the belly where it belongs. So we'll move on. Symptoms of GERD, and again, additional illustrations: a lower esophageal sphincter, which appears closed, versus one that's staying open and allowing gastric contents to reflux up. This should seem relatively self-explanatory. I won't belabor it, but in terms of symptoms, we distinguish typical versus atypical symptoms. Typical are the classic, the heartburn, regurgitation, can go so far as calling chest pain a a typical symptom. We distinguish those from the atypical symptoms, and these are the ones more remote from the area where the reflux is actually affecting. This causes painful swallowing, or what we call dysphagia. Esophageal bleeding, those respiratory complaints, cough, asthma, laryngitis. Chronic acid exposure into the mouth, especially at night, can lead to erosions of your dental enamel. And belching, bloating symptoms. All of these are important factors in diagnosing GERD as well. We do tend to see that there is quite an amount of crossover with other conditions. A lot of these complaints are non-specific or seen in other conditions. Chest pain, obviously, we need to be ruling out cardiac disease. Professors I trained with had a saying that common things are common. And commonly, we see abdominal pain often be pain secondary to gallstones or gallbladder disease. So we need to, with upper abdominal pain, we need to rule those types of conditions out. We rule those out along with following up any reflux workup, which we'll touch on shortly. Gravity being a big factor with a loosened lower esophageal sphincter, patients will typically say that their pain is worse at night when they're laying down. Doc, I need to lay on 3 pillows or sit in my chair upright to sleep at night because the pain's so bad at that point. Also, true GERD disease tends to be responsive to proton pump inhibitor therapy, antacid therapy. And why is this important? This is the first and mainstay treatment that your primary care provider is going to try to put you on. As a surgeon, I'm interested to know that because the evidence that we've seen is that patients whose symptoms at least even temporarily respond to proton pump inhibitor antacid therapy are the ones who will have a favorable outcome with reflux surgery. Patients that don't end up seeing benefit or noticing a difference when they're on PPIs or when they miss a dose of their PPIs, those patients are, based on the literature, less likely to see that kind of benefit, the optimal benefit from reflux surgery. What can GERD lead to? It can lead to several things we touched on: esophagitis, or inflammation and ulceration of the esophagus. This is an image of an endoscopy at the lower aspect of the esophagus, and you can see these ulcerations and irritations here. Clearly, this does not look like happy tissue. Upwards of 25% of patients with GERD will have some degree of esophagitis. It can be graded anywhere from A to D depending on the severity, and with esophagitis, you should see esophagitis improvement with PPI therapy within 8 weeks of starting that therapy. Esophagitis can progress to scarring in that area, leading to circular scars or strictures. Again, about 1 in 5 patients, 1 in 6 patients can develop these. Importantly as well, chronic GERD and reflux exposure of the esophagus can lead to a condition called Barrett esophagus, and that's what you see here. And while esophagitis is a simple inflammation, Barrett esophagus is the esophagus' response to chronic acid exposure, so much so that the esophageal tissue actually adapts and becomes, under a microscope, more to look like stomach tissue, gastric tissue, which is accustomed to handling a higher acid load. Now, if that was where everything stopped, that would be one thing. However, Barrett esophagus is a known risk factor for developing esophageal cancer. It is not cancer itself, but it is a risk factor, and it's known that once this is established, then more serious measures need to be taken to mitigate that. Barrett's esophagus, as it progresses, can become more atypical on the road towards cancer, from uncomplicated to low versus high-grade dysplasia. If there's no dysplasia or precancerous changes, then it can be observed with serial endoscopy anywhere from every 3 to 5 years to every 6 years. By the time it progresses to what's called high-grade dysplasia, which is the short step right before esophageal cancer, EMR or endoscopic mucosal resection is the treatment standard of choice, which expert gastroenterologist goes in with a camera, typically under some sedation, and they remove the surface of the esophageal lining to get back to a more normal appearing tissue. Slide jumped a little forward, but the EMR and all the Barrett's mitigation is done in order to prevent progression to esophageal adenocarcinoma, which is what you see here, and esophageal carcinoma being one of the more deadly, albeit uncommon cancers. It's often, unfortunately, recognized late after it's more advanced than we would prefer, and frequently not treatable by that time. So surveillance is something that we continue to advocate for. So patients getting workup, taking a step back for GERD, they've tried their proton pump inhibitor. They are still having difficulty. Your primary care doc may send you to a GI, to a gastroenterologist, who's going to do an endoscopy. They're going to look for those changes, the esophagitis, the Barrett's, what have you. They will also have you get what's called an upper GI swallow. It's a video fluoroscopic or video X-ray study that we use to follow the contrast that the patient drinks down through the esophagus to see it going down the esophagus and into the stomach. And we can see whether it refluxes back up into the esophagus. Upper GI swallow also allows us to identify if there's a hiatal hernia, which this patient you can see does. You can see the esophagus down to this area, and this bulbous stomach is actually sitting above the diaphragm here, and the rest of the stomach is down here where it should be. But this is clearly a hiatal hernia, which will need to be fixed along with reflux surgery. Ambulatory Ph testing, which has several forms. This is a Bravo capsule. This is not typically this size. In real life, it's about the size of a pencil eraser. It's placed endoscopically by a gastroenterologist in the lower esophagus and kept in place until it falls off within 24 to 48 hours. That wirelessly records high acid events. Greater than 6 minutes in an hour is diagnostic for GERD reflux. Less than 4 minutes in an hour is non-suggestive of GERD, and in those cases, further workup should be done to determine why else patients could be having symptoms. Manometry is the fourth part of this workup, which has become pretty standard. High resolution manometry is done with a catheter that is placed down through the nose, through the back of the throat, and down into the esophagus. Each one of these segments in the catheter measures segmental pressures, and the output, this is done over about 15 minutes in a GI office. The output that we see from this looks like this bright, colorful readout here, and this tells us over a period of time how is the esophagus contracting. Is it moving in a rhythmic fashion? Is it crunching down all at once, which we tend to see in something called a nutcracker esophagus? With reflux, we tend to see the lower esophageal sphincter pressure being characteristically lower than an unaffected patient. Manometry also allows us to definitively establish that patients don't have a condition called achalasia or any related condition such as achalasia. The concern for achalasia being that the lower esophageal sphincter in that case is squeezing too much. It's too tight. And in the process of it being too tight, it can cause some dysphagia and some similar symptoms. However, if we do a reflux surgery and a wrap to tighten that area, and it's already too tight, we can make the patients markedly worse. So we want to be certain that we're doing the right operations for the right patients. How about CAT scans? I love CAT scans. They give me a lot of information. If you for any reason have had a CAT scan and you see me in the office, I'm going to want to see it. I'm going to be interested, and it's going to give me a little some more information. If you're seeing me in the office and you haven't had one, having had these 4 other studies, it's not something that I routinely require anymore. I don't put patients through additional unnecessary radiation risk and additional expense of additional unnecessary studies. So while I'm certainly interested, I don't require those. This slide, certainly busy, and I show this slide simply to demonstrate that from three different sources, the American Gastroenterology Association, the Society of American GI and Endoscopic Surgeons, and the National Institute for Clinical Excellence. There's a variety of guidelines. There's a large amount of crossover, but there's some disagreement among different sources for what is GERD, how do we manage it, what are the cutoffs, what are the guidelines. Hopefully we're able to distill down the salient points for the sake of patients tonight, and work through a lot of this noise. Moving on to medical therapy. So medical therapy, again, a great deal of you are likely on or have been on or are soon to go on. GERD has been an old problem for millennia. Truly millennia. There have been remedies. People have tried a number of things, and I've still to this point not been able to find out what's in Mother Siegel's curative syrup for dyspepsia or Johnson's digestive tablets. For decades, patients will swear that they get better by drinking pickle juice, and without any scientific evidence whatsoever. Families will swear by it. Question of whether that's a probiotic effect of the fermentation process. If it helps, that's great. Coating agents have been used literally for millennia. Pliny the Elder in ancient Rome wrote about a number of things. He also wrote about his GERD and how he would use crushed coral, which contains calcium carbonate as a remedy to treat his GERD. And lo and behold, calcium carbonate and alginates we now see in Tums and Maalox and Rolaids. So the pink stuff as well. In 1981, things took a jump forward, and histamine blockers or H2 blockers came on the scene, Pepcid being one of those, initially prescription and subsequently over the counter, working at the cellular level to decrease acid production as opposed to mitigating symptoms. 1988, proton pump inhibitors such as omeprazole took over. H2 blockers still having a role, but proton pump inhibitors over the next 2 to 3 decades have become the standard of care and are the mainstay for GERD treatment. They are excellent medications at treating your GERD symptoms. They are highly effective. However, they are often misused or overused. I see countless patients in the office that are on proton pump inhibitors indefinitely with no plan to get off of them. The American GI Association guidelines specify that PPIs should be, when used properly, used for only 4 to 8 weeks. And then, at that point, they should try to start weaning, trying to decrease the dose or trying to get off of the medications altogether. If patients can't get off of those, then we need to be asking why, looking into it more. And that's where endoscopy and further workup can come. We can also try increasing to 2 times daily If patients get an show a benefit with increased frequency, then that's still a positive sign that reflux surgery could be beneficial. But there are long-term use concerns. Altering the acidity in the GI tract can lead to a number of long-term fallout, both chronic and acute kidney effects at various levels and various pathophysiologies. Altering the GI tract, we can see increased risk for Clostridium difficile, which is a bacteria in the colon that causes diarrhea. We typically see that with antibiotic use, but altering the GI microflora in any way can also lead to that. Changing the character of reflux, even if it's not acidic, can also increase risk for pneumonia. Altering the acidity in the stomach will also change calcium and magnesium absorption, which has been seen to lead to osteoporosis and pathologic fractures. Gastric cancer, it's down here, and yes, it is very, very rare, has been described in the literature as showing a slightly increased incidence on chronic PPI therapy. Now, this is in no way to say that there's a 1 + 1 = 2 level of certainty. If I take a PPI, I'm going to have gastric cancer. But if you have other family history or other concerns, and this is the long-term plan for your reflux, it may be something to revisit. Moving on to surgery. Important principles for surgery. What are goals for surgery? Number one, restore the pressure of that lower esophageal sphincter. As long as it's loose, then reflux will be able to happen. And if there's presence of any hiatal hernia or hiatus hernia, that has to be fixed as well. Over about 7 decades, surgeons have tried fixing one or the other in various minimalistic ways to treat reflux. And they found that it's not been effective unless both the lower esophageal sphincter and the hiatal hernia are adequately treated. Distinguishing again, full versus a partial wrap, we'll talk about surgical approaches, whether the historical open or laparoscopic or more recently robotic surgery. It is a general anesthetic, which means a breathing tube and in during surgery, and you're all the way asleep. It is an overnight stay, and there's a regimented diet following surgery. Next, I'm going to show some videos, and these are videos and images of real surgery. I'll give everyone a warning if any of the images make anyone uncomfortable. Pause the video. We can move on. But thank you. So, looking at starting points for what we find when we are operating from within the abdomen. 2 images here, 2 different patients. What we are looking at is the stomach and also the stomach and the esophagus here, the esophagus higher up here, and this patient is getting regular reflux surgery. This patient's getting reflux surgery with a hiatal hernia repair. This patient, you can see this characteristic arch here, is an opening in the diaphragm at that hiatus that's too large. It's allowing the stomach the opportunity to push up into the chest. Next to tissue here, we see the liver, the spleen. The heart sits right behind here, here behind the diaphragm. But you can see here, the muscle doesn't have that arch or that hole where the stomach can be pushing through. So this patient does not have a hiatal hernia, whereas this one does. Moving on, with respect to wrap, what do we talk about with a wrap? An animation may be an easier way to understand. What we're again seeing is lifting up the liver with the esophagus, leading into the stomach, and the esophagus is encircled with a rubber band. We're talking about a wrap taking this part of the stomach called the fundus, passing it behind the esophagus and around onto itself and placing stitches to create effectively what's a one-way valve, allowing GI contents to go down but not back up. There are a variety of wraps that have been tried. The Nissen or 360-degree full wrap is standard of care in the United States. Partial wraps specifically a toupee, posterior 270-degree wrap. You can see the stomach doesn't come all the way back, is somewhat looser. Europeans advocate that for lower incidence of any kind of dysphagia or sticking sensation after surgery, but the reflux benefit is still questionable. Dora fundoplication isn't routinely done for reflux so much as other gastroesophageal conditions. In terms of surgical approach, again, the old incision used to just be from sternum down to umbilicus and done under the naked eye. With laparoscopy, a series of small incisions across the upper abdomen allowed a minimally invasive approach, seeing things much better. But you can see here, these are laparoscopic instruments on a training module, and you can see while they're achieving the goal of cutting this circle out, they're working more or less like chopsticks, is how I describe them, which has a steep learning curve and can certainly be better. I'm going to jump out of the slides here and show a video of laparoscopic approach, and you can see these instruments are not moving as well in concert, and the picture with the cameras is less than ideal. It's kind of grainy. And the operation, this is the way I learned how to do this operation before robotic surgery became available in widespread fashion. It can certainly be done, but if there's a better way to do it, then that was certainly to the benefit of our patients. I'm going to jump back. Now, moving on to robot-assisted laparoscopic surgery. You can see we've moved from chopsticks to instruments that have wrists. And by the time I have a wrist, I can achieve a level of precision with my movements in both hands, far beyond operating with effectively chopsticks. We'll look at this. Video is produced by the manufacturers. It's a little melodramatic, but I think it does a good job of illustrating what the components of the robot in the operating room is. It's three parts: a cart that has the robot, the tower, which is the brain, and then the console where the surgeon actually sits. It has 4 arms, which gives us an extra hand to use. One of those arms goes in a camera, and then we have 3 hands to use instead of our 2 hands. This is the console, and that's a 3D viewfinder that gives us 3D vision with the robot into the abdominal or chest cavity or wherever we're operating. At the console, the surgeon sits and uses these hand pieces, and the robot exactly mimics the surgeon's movements in a very precise fashion. There are a number of software safeguards to prevent any injuries or equipment errors. It's been very well vetted and has cornered the market, at least for now. The robot truly does not make you move for it; it moves to you. And we select a patient cart, and we move the robot in. And position these arms exactly the way we need to approach each problem in the best way that we can. I'm going to try to move on because I know it's getting late. So this next video is a comparison. This is a robotic procedure. This is actually a more complicated procedure. The patient had already had a hiatal hernia repair, and this was a recurrence. This was a video that was provided to me at a training by a surgeon in Chicago, Dr. Gamagami, and we appreciate his help in bringing us along with the excellent technique. Now this video is at 2x speed. It's not this fast, but it's certainly, you can see it's largely bloodless, and we're seeing a precision of movements and movements with wristed instruments that just don't have any comparison. And once I discovered the applications and the benefits for this, I have no reservations, and I'm reservations of offering robotic surgery for these procedures in the right hands, knowing that if this was my family, this would be how I want the operation to be done. I'm going to move along a little bit. What the surgeon is doing is dissecting out the hernia sac to define the stomach and the esophagus. Once that's done, this patient has a hiatal hernia, and that's what you're going to see now is actually placing stitches in a way that looks almost sci-fi with the precision that these stitches are being placed, and he's tying these stitches almost like he's tying his shoes, and it's truly that simple and that precise. And those stitches will tighten the hernia, tighten the hiatus sufficient to keep the stomach back where it should be, and prevent any wrap from slipping back up. We're going to move on. After surgery, it is an overnight stay. Patients start on a clear liquid diet the following day, as long as they can get that, as long as they can get liquids down on post-operative day 1. We advance them to a full liquid diet for 1 week, followed by soft foods for 1 week. It's a regimented progression, and we don't want to overstretch the wrap or put stress on it. After that point, we slowly add additional foods. There's a variety of diets. I advocate the Pittsburgh Nissen diet. It's an excellent resource with examples of what to eat, what not to eat, what a sample diet appears to be. Risks for the surgery. Side effects, we talked about dysphagia. Sticking sensation or pain when swallowing. That can be largely from swelling at the wrap at the time of surgery, and that does tend to get better with time. In terms of dysphagia, if it's not improved within 12 weeks, then we'll have GI put a camera down, an endoscope down to perform dilations. Bloat Syndrome has largely gone away, but it is still a consideration. About 5% of patients can develop uncomfortable filling of their stomach and GI tract with air without the ability to belch or vomit or evacuate their stomach. We do try to minimize that. Less specific bloating and some gas can be seen after any reflux surgery. In terms of surgical complications, we always tell patients bleeding, infection, and an adverse reaction to anesthesia are considerations, and injury to what's in the neighborhood of what we're operating in. And again, that's liver, stomach, esophagus, spleen. Very rare is an injury to the stomach or esophagus. If there's anything that we see at the time of surgery, we're able to address that. Any delayed presentations of an injury can require returning to the operating room to complete that repair. Again, wrap swelling tends to improve with rest and just staying on a liquid diet. Wrap failure or slipped Nissens, there's a variety of configurations that have been described. You can see this, all the stitches completely disrupted. Properly placed stitches would make this far less likely. In this instance, the wrap remains intact, but part of the esophagus and stomach herniated back up into the chest. In this case, the stomach is all still in the belly, but had herniated above the wrap and can cause some dysphagia, or the transhiatal herniation where the wrap itself completely goes up into the chest. Do these require surgery? These can happen anywhere 2, 3, 10 years down the line. They don't all require surgery as long as food and liquids are going down okay, and the patient's not having debilitating symptoms from it. We leave good well enough alone because repeat surgery does have higher risks than initial surgery. I'm going to touch on a few emerging treatments, and then we'll have a few minutes for some questions. The Strata Procedure, very briefly, takes radiofrequency energy and directs it through an endoscope and a small power source to the area around the lower esophageal sphincter, and effectively burns it and scars that area to thicken it and tighten that area. It does show some studies do show that patients are able to get off of PPI therapy as a result of this. Long-term results haven't been available yet, and the patient's sensations of dysphagia after scarring at that area haven't borne out a clear advantage to make it standard of care. Transoral incisionless fundoplication, or the TIF procedure, is an interesting endoscopic procedure. It's quite technically challenging. GI doctors themselves, rather than general surgeons, endoscopically suture the stomach around on itself 270 degrees, but they do it from inside the stomach instead of outside the stomach. So the procedure is done in the GI lab without requiring any incisions or addressing other organs. It is technically challenging. The sites that have shown benefit have had expert users as opposed to novice users. There's mixed results. This doesn't allow for closure and repair of any hiatal hernia. Alternatively, on the other hand, magnetic sphincter augmentation, or the LINX device, is another interesting device that is FDA approved. It's a magnetic ring, titanium encased rare earth magnets that allow for expansion when placed around the lower esophagus. It allows for, if it stretches, then the patients can actually belch and evacuate their stomach, but it provides 10 to 15 millimeters of mercury pressure, just enough to increase the LES pressure to become more physiologic. Being that it is a surgical procedure, it does allow for hiatal hernia repair at the time. It is a foreign body. There are any patients that have metal allergies aren't candidates for this. I attended the training for this and was trying to incorporate it into my practice. I did find some resistance with a number of insurances for getting approval for this. So it's a more regimented workup with very strict criteria, and it's an uphill battle to get this approved for patients that don't want to wait a year to get it approved. The TIF procedure, again, the image of the TIF without any stitches on the outside here, just takes the fundus and wraps it around on itself, done endoscopically. And this is an image of the actual LINX device. Each one of these contains magnets, and if this gets pushed down further on the surgeon's finger, this stretches out. And this is the image of the LINX, which is positioned around the lower esophageal sphincter to provide durable LES pressure restoration. If these do develop complications, they are a challenge to remove, and that is another barrier for those to become mainstream. Very quickly, conclusions. Gerd is very common. It affects a large number of people. Lifestyle and medical therapy can help symptoms, but we do have to have concerns about PPI therapy with respect to long-term use. I'm a large advocate of minimally invasive and now incorporating robotic surgery as the gold standard, an operation I believe in. I'll be interested to see where these other techniques go, but we need to see where the long-term data stays. Any time for questions?
Thank you, Dr. Richardson. That was very informational. We appreciate that. We're going to head into some of the questions now, and for our audience, if you'd like to stream any to our chat box, we'll get as many questions answered as we can this evening. Just going to run down these, Doctor, in no particular order. So, how do antacids affect the gut balance?
How do they affect the gut balance? Well, we did touch on that. Altering the acidity in the stomach inevitably does have downstream effects. Now, part of the role of the upper small intestine and the duodenum is to neutralize those acids before getting lower down into the further down the small intestine and the colon and the gut that people tend to experience as their intestinal tract. The risk of altering the gut flora, as we were talking about, is the consideration that makes concern for developing Clostridium difficile, diarrhea, or very simply altered gut microflora consideration. And if any patients are concerned about that, there's no downside or restriction from using probiotics to maintain what each person feels is a healthy gut microflora.
So having probiotics doesn't increase the reflux or contradict?
No. There should be no effect. By the time we're affecting reflux, it's largely a functional and an anatomic condition. The medications don't affect reflux so much as what is refluxing. And what is refluxing is able to help with symptoms, but the reflux itself requires more of a mechanical solution.
Okay, understood. What nutrients are flushed out using a PPI?
What nutrients are flushed out? Well, we talked about calcium and magnesium being critical for bone balance, and it's not necessarily that they're being flushed out as their absorption is altered. In terms of other important nutrients and vitamins that are absorbed within the stomach, B12, intrinsic factor, iron, those we don't necessarily see any change in those as a result of PPI therapy.
You touched on this some, but does long-term use of PPI contribute to osteoporosis?
It can. The literature has suggested that, and it's again, osteoporosis is multifactorial, and women are certainly at more risk after losing the protective effect of estrogen. I encourage any middle-aged to elderly females to use calcium supplementation at a minimum, and keep follow-up with their primary care provider to make sure their bone density isn't getting down into a dangerous level where osteopenia, which is pre-osteoporosis, can develop into osteoporosis with the true higher risk of pathologic fractures.
Okay. Is it true that over-the-counter medications such as Prilosec contribute to dementia?
There's been question. There's not a clear cause, but these are these kinds of long-term concerns that these medications have been out for anywhere from 30 to 40 years. So we're finding out more about the long-term effects, and I don't think anyone was anticipating that these were going to be used long-term. Again, the guidelines suggest 4 to 8 weeks of use, and then revisit and determine why these symptoms are still here. They were never intended to be a mainstay or a maintenance medication on an ongoing basis.
Okay. Are the treatment procedures and surgeries you mentioned generally covered by insurance?
With proper documentation of the workup that we talked about, making sure that there's reflux documented on an upper GI, or endoscopy evidence seeing esophagitis and ulcerations or Barrett's esophagus, or a positive pH study that shows that acid exposure over time is experienced more frequently, higher frequency of acid exposures than, I believe I said 6 minutes per hour is the cutoff. And as long as there's objective evidence documenting that this is truly Gerd and or a hiatal hernia, the guidelines would suggest that likely any patient with a hiatal hernia has some degree of reflux by virtue of the LES being in an improper position, that anyone who's an appropriate surgical candidate for a 2-hour operation should be considered for a hiatal hernia repair, which necessarily includes a reflux operation along with that.
Thank you. What medicine can you take if you are allergic to proton pump inhibit?
You could certainly try H2 blockers, famotidine, or I believe ranitidine was taken off the market. But yeah, H2 blockers, Pepsid is certainly an option. It's an older medication, and it's not the gold standard in the GI office for treating Gerd, but it can have beneficial effects in decreasing the acidity of the stomach. PPIs, they further market themselves as encouraging actual healing of the tissue, whereas H2 blockers less so.
This is specific to this particular person. They said that they were taking amiprozole for EOE, and will that be problematic long term? Maybe tie it in for the rest of our audience here.
Can you pronounce or spell the medication one more time? Omeprazole?
Yes.
Omeprazole. So that is a PPI. That's the classic. That's Nexium. That is the classic proton pump inhibitor that we talk about, and all those risks that we talked about, risks of chronic injury to the kidneys, altering the gut microflora, pathologic fractures, osteoporosis, increased incidence of pneumonia, all these things. These are subtle increases, but with the number of people that are on these and the number of incidences and increased cases of these in patients on PPIs, the evidence is able to demonstrate that there is an effect, even if it's a subtle effect. So.
Okay. Can gallbladder issues contribute to chronic heartburn?
Gallbladder is a great pretender. Gallbladder in and of itself doesn't contribute to chronic heartburn, but with everything in the neighborhood of, within 5 to 6 inches of each other, gallbladder symptoms can often be mistaken for indigestion or heartburn. Gallbladder pain is pain that we typically characterize as what's called biliary colic. It's cramping pain more on the right side than the left side, but it can be all the way to the midline. It tends to be precipitated more by fatty or greasy foods than foods that are spicy or the typical GERD triggers such as alcohol or chocolate or spicy acidic foods, tomatoes. Those types of things. But any pain, if you still have a gallbladder, you should consider, is this my gallbladder as well? Don't go and get a Nissen done before you get your gallbladder checked out.
Perfect. Does taking Prilosec cause cancer if it's taken over many years?
Does it cause cancer? No. I can't make a definitive statement that it causes cancer. As I was saying with respect to gastric cancer, a slight increased incidence has been seen, but gastric cancer is so rare, only 200,000 cases in the U.S. per year. It's very difficult to tease out what causes those. We know foods with a lot of nitrates, like hot dogs, are risk factors and contribute to developing gastric cancer, but I can't say that with that degree of certainty that PPIs are going to cause cancer.
Okay. So this person had been told that their asthma is getting worse, and that was due to gastric reflux. And will the procedure replace the need for stomach meds?
Ideally, yes. Ideally, yes. After surgery, my practice is to typically at least leave the patients on their antacid medication for 2 to 4 weeks, let the dust settle, let them get healed up and get used to their new diet, and then work to get off of the antacid medication. If episodes happen, I would still try to favor some of the coating agents like Carafate or Tums or Rolaids as opposed to going back on the PPI therapy. Are there patients who've had this that still require PPIs? Unfortunately, there are. They're not common. But yeah, if the operation's done appropriately for the right reason, then the PPI therapy should be able to be stopped.
Okay. We have time for another question or two.
Okay.
This person had hernia surgery recently, so can they still have this surgery?
What kind of hernia?
They didn't mention.
Okay. All right. So if they had a hiatal hernia surgery done recently, then very likely they had this scope of procedure done at that time. Whether they had an incisional hernia, umbilical hernia, or an inguinal or groin hernia, none of those should be any restriction from having reflux surgery or hiatal hernia repair or combination of both in the future. Now, their surgeon might want them to have a little bit of time to heal from their old wounds before disturbing his or her repair, but there shouldn't be any hard and fast rules that after hernia surgery you can't have reflux surgery.
Okay. Is laryngospasm one of the symptoms of Gerd, and how can it be prevented or treated?
Laryngospasm can be one of those atypical symptoms. It can also be from a variety of other causes. First and foremost, seeing an ear, nose, and throat specialist to have that diagnosed definitively and take other causes off of the table before attributing it to reflux would be advisable. Laryngospasm as the only symptom would not be sufficient to mandate reflux surgery. But if there is concern that this could be from reflux, then that could be better documented with the endoscopy and the upper GI and the pH study.
Okay. Thank you again, Dr. Richardson. We've come to the end of our time. A recording of tonight's lecture is available on bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Again, please visit bch.org for information on the COVID-19 vaccination. Thank you for joining us, and have a good night.